I think one of the big challenges in the United States is that the healthcare system is so focused on resource generation. That focus on revenue has detracted from the focus on service and quality and improving care for underserved people.
Sanjeev Arora is the founder and director of Project Echo, a global telementoring nonprofit dedicated to disseminating knowledge in rural and under-resourced communities. Since 2003, there have been 6,818,000 Echo session attendances, 7,457 programs launched, and 1,456 hubs in 212 countries and areas.
So we typically are not able to change the whole healthcare system, but we certainly bring in this concept that if you upskill the workforce, regardless of what system there is, better care will occur.
Today on our channel, we have our esteemed guest, Dr. Sanjeev Arora, who is the founder and visionary behind Project Echo, which is a huge growing, telemedicine and telehealth organization, to my understanding. So thank you for being here with us and being willing to talk with us today.
You're welcome.
Yeah. So I just wanted to begin by having you tell us a little bit about the organization and kind of how you got into it and how you began to start it.
So I'm a gastroenterologist by profession, and I'm a professor at the University of New Mexico. And as you are aware, since you live here, is that this is a tremendously underserved area for healthcare in the United States. So in 2001, I'd gone to my clinic here at the university hospital, and I saw a patient there. She was 43 years old, and in the room with her were two children. There was a 14-year-old boy and a 9-year-old girl. And I asked her, "How can I help you?" And she said, "I have hepatitis C and I want treatment." So I said, "Of course, we'll do that. How long have you had it?" And she said she'd had it for 8 years. So I said, "Why did you not come earlier for treatment? I've been here for 8 years and been treating hepatitis C." And she said that she had called my nurse and there was an 8-month wait to see me. Now, as you are probably aware, even today for specialty clinics at the University of New Mexico, there are some long waits. This is not just true for the UNM, it's true for specialists around New Mexico. So I said, okay, I understood you couldn't come right away, but now it's 8 years. What happened? She said, your nurse told me that I would have to make 12 trips to see you while I was getting this chemotherapy-like treatment with weekly injections and pills. And there was no one in my area, no specialist who could treat me because there aren't any specialists there. And but I'm a single mother and there's no way I could take so much time off work and make 12 trips to see you here. So I decided not to get treatment. So I said, "Why did you come today? What changed for you?" Mm-hmm. And she said, "I'm having pain here in the right upper side of my abdomen." And I did an ultrasound and she had a cancer of her liver this big. Now it was too late. She was willing to come, but it was too late for her to get treatment. And she passed away 6 months later, leaving these two children. So I was saying, why did she die of a disease that I knew how to treat? It was a curable disease. And the answer was, she died because the right knowledge didn't exist at the right place at the right time. And she didn't have the ability to get to the right knowledge. We now know that this problem is a global problem. Almost 6 billion people in the world don't have access to the right knowledge at the right place at the right time. That's 3/4 of the world's population. And without the right knowledge, you can't get the right care. It's impossible because you can't make the right diagnosis. You can't get the right treatment, even if the medicine is available. So, but the challenge I was facing in New Mexico was there were 28,000 patients who had been diagnosed to have hepatitis C. And only 1,500 had been treated. Mm-hmm. There were 2,300 prisoners here who had been diagnosed and not a single one had been treated. So trying to figure out how should I get treatment to all these people when I'm working all the time and it's complicated treatment. And so I developed Echo with the idea to democratize my expertise so that anyone in New Mexico can have access to treatment. And that's how in 2003, I launched my first Echo project in New Mexico for hepatitis C.
Yeah, that's that's a very unique story, and it's interesting because now it addresses all that need that we talked about. But I feel like at the time, I think telemedicine exists, but kind of like talking to a patient. So how did you develop that almost teaching model that's inherent in Echo of I'm going to share this knowledge with people so that they can teach other people or treat other people?
So telemedicine has existed for a long time. And certainly I had that option that I could go in front of a camera and a patient could be sitting in rural New Mexico, 200 miles away, and I could see the patient and treat the patient. But the principal constraint wasn't the 200 miles. Okay. The principal constraint was my time. Mm-hmm. I was already working all the time. If I would see a patient on a camera and see them versus seeing them in my clinic, I would still only be able to treat one patient. It would not improve the total number of patients seen, even though certainly I would be able to overcome a geographic divide. And that's an amazing thing, to be able to overcome a geographic divide. When my challenge was there were 26,500 patients in New Mexico who needed treatment, I couldn't do it with telemedicine. I had to figure out a way to multiply myself. We call this idea force multiplication. That is, exponentially improve the capacity to deliver best practice care. Mm. And that was the idea behind Echo. So telemedicine, for this reason, is an inadequate total solution to the problem. And the reason for that is, if you can imagine a specialty shortage in the United States, in New Mexico, what if you were to go to a low-income country in Latin America? Or even worse, if you went to Africa, the number of specialists would be 50 times less. So you can imagine deploying specialty expertise over a camera alone doesn't solve the problem. You have to expand capacity to treat, not just treat a patient in their local area.
Yeah, that makes a lot of sense. And so can you describe a little bit about how that works, how it's built? I mean, I've been lucky, I've seen a few of them, and it's very interesting the way that you do it.
So the question was, how do I make sure that every person in hepatitis C in New Mexico gets treatment close to their home? So I developed the Echo model based on 4 ideas. First was to use technology to leverage expertise. There was no such thing as Zoom at that time in 2003. So what I did is I bought a used telecommunication bridge and put it in the basement. And essentially became a very small telecommunications company where 25, 30 people could dial in on a video conference with me. The second key principle of Project Echo was to share best practices. So I would have the technology, I could share my knowledge, democratize my knowledge. But when I shared my best practices, these doctors said, this is chemotherapy. We are primary care clinicians. We can't do this. So I asked myself, how did you become an expert in treating hepatitis C? So I did my fellowship in gastroenterology in Boston, in Massachusetts. And I would see a patient, present to my professor, see another one, present to my professor, another one, professor. And after 2 years, they said, you're a gastroenterologist. I said, aha, I'm going to use this model to create new hepatitis C experts in New Mexico so that the capacity increases, not 10 times, 20 times. And anybody can now get treatment close to their home. So what I did is I drove around the state, went to these rural areas, and I said, look, guys, people are dying in your community. Would you be willing to be mentored by me? So they said, what do we need to do? I said, all you need to do is join me once a week on Wednesday at 3 p.m. and the rest I'll take care of. And then be willing to treat your own patients, but also accept referrals from your other doctors in your area. So I found 21 clinicians all over New Mexico who would be willing to do that. And I started my first ECHOs. But this is the third principle of ECHO, is case-based learning, all teach, all learn, very similarly to how you learn in medical school or residency. And the fourth principle was I would track outcomes of these patients on the internet. So once a week on Wednesday afternoon, I would have this session where all 21 would join and one by one present patients of hepatitis C to me and to my psychiatrist and pharmacist, and we had a team, and we would discuss those patients. We would tell them what to do. And 15 minutes, I'd give them a lecture on hepatitis C. But it was very important not to make ECHO a lecture. It's much more about cases. But what we found was in a year, they became total experts. And in 18 months, the wait in my clinic fell from 8 months to 2 weeks. Anybody could get access to treatment within 2 weeks. And we were getting good results. So we started doing research and we found that ECHO was doing one other thing which we didn't expect. It was producing joy of work for these rural clinicians because they were isolated. And they had gone to medical school and there was a lot of learning and practicing, etc. But here it was all one patient after another, no way to learn because they didn't have any time. So this was different. The second thing, their self-efficacy went up dramatically. Remember, they originally said, look, we don't feel comfortable treating hepatitis C. But the most important event that occurred in the history of ECHO was that we published a study. We got a US government grant in the New England Journal of Medicine, which is, as you know, the leading medical journal in the world, where we basically published a paper saying that these rural clinicians could give chemotherapy in a rural area or in a prison and get the same outcomes as university specialists. This was a game changer because the moment the paper came out, next morning I had emails. Oh, we want to do it for HIV in Africa and TB in India and so on and so forth. And the massive global rollout of ECHO in the world started literally on that day.
Oh, that was the tipping point.
That was the tipping point because ultimately people wanted to know that, yeah, you're having these generalist nurse practitioners, etc., treat complicated problems, but can they do as good a job?
Right.
Without that, just because they're happy and have self-efficacy is not enough. You need to be able to do a really good job. And we were able to show that they could do as good a job with us as us. And so that was a game changer. And then we realized we want to help billions of people. So we set ourselves a goal. We want to help 1 billion people relatively in the next many years. And then we started teaching other universities, other not-for-profits around the world, other countries, ministries of health around the world, how to do ECHO for whatever they think is the need in their country. And now we have 6.7 million learning attendances in 211 countries and areas and territories, and it's everywhere. And we've developed a software platform to track outcomes, etc.
Wow. Yeah, that's a huge expansion from the beginning to all the way to the global level.
It took 20 years, but now we have already impacted the health of more than 200 billion patients worldwide. And we want to do a lot more because this problem is so serious, not just in healthcare, but also in education, where there are lots of students all over the world that don't have a school teacher that knows how to give them a good education.
Mm-hmm.
So we've expanded into education, where we train school teachers to be better teachers.
Oh,
In
wow.
India, we have expanded into agriculture to train farmers in best practices on farming and so on and so forth. So there's lots of different now expansion occurring into different areas.
Wow. So how does it work? Do people like visit with some expert on a weekly basis and then graduate from that program kind of, and now they're able to do it themselves, or?
There are two types of programs in ECHO. One is a cohort-based approach. So we could say, okay, we are going to run a 20-week session, ECHO, once a week for 20 weeks for management of headaches or for management of diabetes or whatever. That's one type of ECHO, and you can come, you can get certified there that you've attended this session and take a written test in the end, etc. But there are also ECHOs which are dealing with very complex problems. Those are continuous ECHOs. So for a primary care clinician to say that, look, I am willing to start treating complicated disease like HIV, where constantly things are changing,
Mm-hmm.
they often want a much longer period. So they're essentially becoming sort of junior specialists in a particular disease. And they want to completely always stay up to date, etc.
Mm-hmm.
So there are ECHOs that just continue all the time. Because in the beginning, it's like, any child first crawls, then walks, then runs, and ultimately could, compete in the Olympics. So there is this learning experience that people have, and some they enjoy the idea that they are gaining a very highly specialized expertise. And they particularly enjoy the idea that they are not just treating their own patients, but they are serving their own whole community.
Mm-hmm.
So you can imagine a situation where there's a small town in Latin America and in Peru, and what is happening is that they don't have any specialists there, but there's one expert in endocrinology, there's another expert in infectious disease, there's another one in liver disease, another one, and they support each other, and people get amazing care because each one is spending an hour a week being mentored and learned. So what can actually happen is the number of patients now getting treated expands dramatically. So, after about 10, 12 years of starting ECHO, we had treated more than 10,000 patients of hepatitis C, which I could never have done on my own.
Right.
So that's the idea, is ultimately each of these empowered clinicians then go and can treat hundreds and even thousands of patients over the years.
So it's really just about sharing that knowledge with everyone and making sure.
It's about, so, there's been models. So building capacity has been a need for thousands of years.
Right.
Okay, this is not a new problem, right?
Mm-hmm.
And so people have tried to build capacity with traditional trainings. They would go to Peru and they would train the rural doctors, and then they'd be coming from the US or from Mexico City, wherever. The challenge has been that it's been very difficult to show the impact of that training on ultimate patient outcomes. It's often like if you have a garden and you water it in January, and then you come back in June and expect flowers are still growing. So ECHO is much more the drip irrigation method of training. It's very high frequency, very low dose. The second is traditional training has to do with democratization of knowledge. ECHO is about democratizing the implementation of best practices. Knowledge is one part of it. But whenever you have problems which are dynamically complex, that is, they are complex problems, but they're changing because new treatments are coming, in that situation, you need guided practice. And what we call this idea all teach, all learn, where the experts are bringing evidence-based knowledge. These learners are actually bringing expertise on what the social circumstances are. What is the culture? What are the barriers to treatment? What does the family want? All of this merges in an echo teleconference so that new best practices, which are customized to the needs of that particular locality, are created. And it is like, if a person has to teach his daughter to drive a car, okay, you just can't invite them for conferences and give them lectures and then give them the keys to the car. What you need is guided practice, because it's a dynamically complex problem. They need feedback, and that practice ultimately creates expertise. So that's what ECHO is designed. It's about implementation. And now we have close to 700 peer-reviewed publications showing that ECHO is effective.
Wow.
And they're coming from all over the world, because all the largest universities in the United States, like Stanford and Harvard and University of Texas, MD Anderson, U Chicago, UCSF, they all do ECHO now.
Okay.
Yeah. So they all publish data, and it all builds the evidence base that this is the best capacity building model in the world now.
That's amazing. So what's it been like rolling it out to different institutions or even across the world, like setting up all these programs and making that happen?
Yeah, in the beginning, we rolled it out in New Mexico. But then we realized that only 2 million people live here, right? If we want to help billions, we have to not just democratize my expertise in hepatitis C or our endocrinologist's expertise in diabetes. We have to democratize our expertise on how to do ECHO. So we developed a process called partner launch training, where people would sign a collaborative agreement with us. We would train them and on how to do ECHO, 2.5 days of training. Then they would go back to their place and start doing it. And then in 2013, I met with Eric Yuan, who's the founder of Zoom. And I was able to get a worldwide Zoom license from him, which then I can give to these different institutions. So in Latin America, for example, in Ecuador or in Mexico or all these places in Uruguay, they use our Zoom licenses and then we developed a software platform which allows digital certification. In order to change the world rapidly, we said we'll give away everything we have for free. So it becomes easy for a Ministry of Health or an academic center to adopt ECHO because there's no money exchange. We basically tell them, as long as you're willing to devote your energies to help your people, go for it.
Yeah, that's really nice. So that way you've kind of been able to spread it.
That's why, now we have 1,463 hubs in the world.
Oh, wow.
These are big universities, they're ministries of health, etc. But they're also big non-for-profits, like American Cancer Society is one of them. American Academy of Pediatrics is another one of them, like that. So we give it to anyone who wants to achieve their mission with speed and with scale, with higher quality and at much lower cost.
Okay. So the goal is to help people, basically, to make it available.
Yeah, that's the only purpose. That's the only purpose of doing ECHO, is to help as many people as possible.
And when you first started it, what was it like kind of having it grow so much? Because I don't know if you imagined it would get this large.
No, I didn't imagine it would get this large, but I definitely realized the potential of the model to make a big difference. But certainly it was challenging to find the resources to take it worldwide because we gave everything for free.
Right.
So we had to raise philanthropic funds and grant funds and that sort of thing.
Okay. And I know that Project ECHO kind of has like a different model that's a little unique in the sense that I remember when I worked here for a bit, you guys gave books about like team building and things like that. Where did those ideas kind of come from, and how does that impact the organization?
Yeah, I think when you have an organization which is not built on making profits, is built around values. It's built around, so Echo is just a means to fulfill our values of service to the underserved, and joy of work, and teamwork. So to develop partnerships with almost 1,500 organizations in the world, which are the largest universities, first of all, it's hard work, and people have to be working for the mission.
Mm-hmm.
So the internal culture of Echo is as critical as the work we do, because they have to be focused on serving their customers, in this case, the largest universities and not-for-profits in the world, so they can convince them that it is truly a good idea to democratize their expertise. Traditionally, there's a lot of focus on equity, right? And the focus on equity has been based on, look, let's give them money. Africa's poor, give them money. And that's an amazing thing. The challenge is there's just not enough money to make everybody in the world rich, all 8 billion people rich. But there is enough expertise if it's democratized in a way that we do in Echo. Or what can happen is that it's not a zero-sum game. When I share my knowledge and I learn from them, which is all teach, all learn, the knowledge actually grows. So it is a very efficient way to bring equity, because the physics of knowledge is it grows with sharing. As opposed to if I have $100 bill and I give you 50, I'm only left with 50.
Right.
So because of that, the principal argument we have is the best way for developed nations to help less developed countries, etc., is to build expertise there.
Mm. I see. So let the goal is to build the community and let them have the expertise to
handle their own issues. And that doesn't mean that outsiders don't help, but ultimately you want to empower them with the expertise to solve their own problems.
Yeah, that makes sense. And it's like a very mission-based organization, so
yes,
people are feeling good to work towards something.
Exactly. Yeah. So because of the mission and the culture, we are able to attract the best talent to work for us at Echo, and that definitely helps in getting our mission accomplished.
And you mentioned like one of your challenges is you're giving it for free, so there's funding. Have you had any other challenges kind of come along? I'm sure, but kind of things that you've learned and realized?
I think one of the big challenges in the United States is that the healthcare system is so focused on resource generation, optimizing revenue, whether it be doctors or hospitals or healthcare insurance companies or pharmaceutical companies, that focus on revenue has detracted a little bit from the focus on service and quality and improving care for underserved people, because underserved people often don't have money. And so it is a little bit of a challenge for a doctor to take their time and democratize their expertise and spend time mentoring others when their income is completely dependent on how many patients they see. So only those people who are oriented towards the mission to help the world actually do Echo. So it is a challenge. Not everybody's interested, but there is the advantage too that we get the mission-oriented people, and one expert can help tens of thousands of patients if they're willing to democratize their expertise.
I see. Yeah. I didn't even think about that, but that makes a lot of sense.
I don't need every gastroenterologist or every endocrinologist to do echo in New Mexico. I have one. He can train hundreds over time. Yeah.
That's the force multiplying.
Yes,
so
that's the force
it
multiplication.
ends up working out. Okay. And then I was just going to ask, like, people who are, our age still in training or doing whatever different things that they're doing, what is your kind of advice for them going forward in their careers?
I think anyone who wants to go into medicine, this is especially important for people who are still an undergraduate. They need to go into medicine, this profession, for the mission.
Mm-hmm.
You certainly make a good living, but going in the profession for the mission of helping other people creates a lot of joy, a lot of professional satisfaction, and a very fulfilling life. So that's the one thing I would say is that there was this Nobel Prize winner, Albert Schweitzer, and he said that, I don't know what your destiny will be. He was a physician. He worked in Africa.
Mm-hmm.
And he said, I don't know what your destiny will be, but one thing I do know for certain. The only ones among you who will be really happy are those who have found a way to serve.
Mm-hmm.
So it's really important to be very clear at a young age that it's not possible to lead a happy and fulfilled life just focusing on making more money or have more power or having more fame. That the principal purpose of life should be to serve other people, and then as you do a good job, you can certainly make a good living, etc. And that's especially true for medicine as a profession.
Yeah, I think that's very, very valuable advice for people to take at age. And I think it's very interesting that, like, especially globally, the idea that there are so many diseases that are untreated just because, not because we don't know how to treat them, but
Mm-hmm.
because there's not resources. So being able to address that is.
Yeah. There are diseases like diabetes, hypertension, high cholesterol. These kind of chronic diseases account for tens of millions of deaths in the world, even when very generic, inexpensive medicines, which in a country like India could be available for less than 50 cents a day for the whole thing, for all these diseases. And yet, 15-20% of people get treatment because people don't know what to do. So in many, many situations, it's not a resource constraint. Mm-hmm. Generic medicines are inexpensive, which can dramatically save lives. But patients don't get them because there's not a trained workforce there. So it's a good place to start there. And I think that going back to your earlier question about service, one of the things that I find in medicine now, there's a lot of burnout.
Yeah.
But people who go into medicine for service, they don't experience the same level of burnout in people who go in for other reasons. Mm-hmm. Yeah. There is a huge immunization that occurs against burnout when you are serving other people and helping other people.
Oh, that's very good. Do you think part of that is, you mentioned it a little, do you think part of that is just like the way the United States system operates with insurance and all these other barriers to accessing care? Or?
Yes, I think that, we spend twice as much on healthcare than most other countries, and most other developed countries. And for low-income countries, we can spend 100 times as much. Mm-hmm. And yet our outcomes, and for example, the life expectancy in the United States right now is the same as Ecuador. Identical. Okay. Much lower than Canada and Japan and Australia, etc. So why is that? I think the system, there was a professor at MIT, he said, every system is perfectly designed to get the results it gets. Hmm. And so we definitely have a system design issue in our healthcare system. which essentially systematically makes it harder for poor people, makes it harder for rural patients, makes it to access care and get best practice care.
Because you've had the opportunity to see how other healthcare systems work around the world, right?
Yes, many, almost all of them, yeah. Yes.
So you know the best practices of each area? Or?
Yes, no, I do know what are the key features of good health systems, yeah.
Okay. And I guess you've had the chance to implement that where you can.
Yeah, these systems are typically governed by politics, ministries of these countries. So we typically are not able to change the whole healthcare system, just like we haven't been able to do that in the United States. But we certainly bring in this concept that if you upskill the workforce, regardless of what system there is, better care will occur, better access will occur, cost will be lower. The Ministry of Health in Kenya published this data where it was costing them $820 per doctor trained in Western Kenya for HIV. And they adopted ECHO and the cost went down to $21.
Oh, wow.
And it was better because of the drip irrigation method. Previously, they had to fly all these people to Nairobi and give them 5 days of training, send them back, and then often turnover would occur or they would forget what they learned. Not so easy, right?
Yeah.
To go for a 5-day conference and then apply all that knowledge. So I think it's a better way. If you can do things at scale with higher quality at lower cost. And so it works regardless of the system you are using in your country.
It allows for sustained growth rather than just kind of throwing things and hoping they stick.
Exactly. Yeah.
Right. And then just to end things, what do you like to do for fun?
I enjoy golf.
Yeah?
Yeah, I enjoy golf. I wish I had more time to play, but I also have 2 daughters. I love talking to them, and they have 2 children each, and so that's also a source of great joy. So I'm going to Puerto Rico, for example, with them, all 10 of us, right? Are my daughters, their husbands, their 2 daughters each, and my wife and I, so that we can spend a week on the beaches. So, spending time with family and then golf.
Okay, that's awesome. That's great. That's good.
I also like meditation.
Oh, yeah? Do you do that a lot? Or?
Yeah, I do it every day. I found this to be very, very helpful in my life. And
Okay, that's very cool. I also try to do it every day as well.
All right.
It's calming.
It's very helpful. Yeah. Good.
Very cool.
Thank you.
Thank you so much for your time.